All right, hello everybody. I'm John Schneider, one of the GI doctors here. This is Kelly, our fake patient, who's drank too much over the years and now suffering a varicose hemorrhage. All right, so we're going to talk about placement of a Blakemore tube, and really the indication for it is refractory esophageal varicose hemorrhage or proximal gastric varices as well. So that would be during endoscopy, you're not able to stop it with banding or sclerotherapy. And then you would need the Minnesota tube or Blakemore tube, which we'll talk about a little bit more, the difference. And it's really meant for a temporary measure as a bridge to liver transplantation or TIP. So these cannot be placed more than 24 hours with the balloon inflated. So this is what we have at Centennial. It's a Blakemore tube, and it consists of a gastric balloon, an esophageal balloon, and then a gastric suction port. And there are three appropriate lumens ports at the proximal edge of it. You may at some point see a Minnesota tube, which is basically the exact same thing, except it has an esophageal port above the esophageal balloon that you could use just for suction purposes. So I think the first and most important thing when you decide to place a Blakemore is to make sure you have all the supplies ready. So a helmet is helpful, not necessary. You will need syringes, and you don't want 10 or 20 cc's because it will take forever to inflate the balloon, so you want kind of larger volume. You would need a manometer or pressure gauge if you have to inflate the esophageal balloon, so that needs to be on standby, then at least 1 or 2 hemostats. You would also want to call radiology because you will need confirmed placement of the appropriate placement of the tube with the gastric balloon inflated below the diaphragm, so call x-ray. If the patient does not have an ICU bed, if you're doing it down here in the lab, came from the floor, you would want to make sure an ICU bed is available. All right, and so placement, once you take it out, it's going to be slightly inflated just to confirm that these balloons have not torn. And you're going to pull these two stoppers out, which is actually pretty difficult. We just did it before the video, so you'll need a hemostat to open those and just squeeze the air out with your hands. The patient will typically be in the left lateral position. Kelly's just supine here. Will need to be intubated if they're not intubated already. You would lubricate the tube. Preferred entrance orifice is through the mouth. You can also do it through the nose, which I've done several times. It typically goes down fine. It's pretty rigid. So you're going to insert this. I'm just going to lay it over her. And there are markings, and you go all the way to the last marking, which is 50 cc's. You want to make sure it's below the stomach. If you feel a lot of resistance, then just put a scope down to be sure you're in the lumen and down into the stomach. First thing you do is identify the gastric port. It'll say GAST balloon, which is this one here. And you're gonna inflate with air into 50 cc's, which is the 50 cc balloon. So as you can see it under Kelly's hand, slightly inflated there. Then you're gonna put a hemostat, and you can pull this off. Now you get an x-ray just to confirm a quick KUB that the balloon is below the diaphragm. Once it is, you're gonna do this method several more times. Right, so hemostat off. So once the tube is confirmed to be in the stomach, you're gonna repeat what we did before several more times to get a total of 500 cc's of air into the balloon. So proceed to the hemostat. And you just gotta do this maneuver again until there's recommended 450 to 500 cc's of air. For the sake of time, we're just gonna pretend we did that all the way to 500 cc's, but you can tell it's gonna get pretty big. And at this point, you're gonna pull out until it's 1 to 2 pounds of pressure, and that's the equivalent of hanging a 500 cc bag of saline. So if that's your preferred method, you could just tie this to IV tubing and hang it over an IV pole and just hang a half-liter bottle or bag of fluid. We typically use the helmet. It's just much easier. The helmet would go on the patient. You're going to maneuver this through. Again, the patient's intubated, and you're simply going to tie to the face mask with some gentle pressure there. The hemostats need to be on the entire time. I would have syringes bedside. We typically leave the gastric balloon inflated by itself for 12 hours, deflate the balloon, and look for recurrent bleeding. If there is recurrent bleeding, you typically reinflate the gastric balloon and then the esophageal balloon. And this is the most dangerous part of it because it can cause esophageal ruptures. So you have to use the pressure gauge to a pressure of 30 millimeters of mercury. but hopefully by this time you're arranging for a TIPS procedure or liver transplant eval. And that's it. If they stop bleeding and have the TIPS, I typically just leave the gastric balloon deflated for 24 hours to ensure there's no bleeding. Then I feel pretty safe after that. If there's no bleeding, that the chance of recurrent hemorrhage is low. You just make sure everything's deflated, then pull it out. And that is it.